Welcome to meeting number 10 of the Standing Committee on Science and Research. Pursuant to the motion of the House of June 18, the committee is meeting to study the antimicrobial resistance. I would like to make a few comments for the benefit of the witnesses and the members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you are not speaking. For those on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, either Floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. And for our first panel, I would like to welcome our three witnesses for appearing before the committee today. I would like to welcome Dr. Louis Patrick Haroy, Associate Professor, Faculty of Medicine and Health Sciences, University de Sherbrooke. We are also joined by Dr. Jerry Wright, Professor, Michael G. de Groot Institute for Infectious Disease Research, McMaster University, also by video conference. And our third witness for today is Professor Kevin Utterson from CarbX, the founding executive director, also by video conference. Welcome to all the witnesses. All of you will have 5 minutes for your opening remarks, and then we will go into round of questioning. So we will begin with Dr. Haroy. You can start. You will have 5 minutes for your opening remarks. Please go ahead.
Bonjour. Good afternoon, Madam Chair and members. I am very grateful for the invitation to speak to the House of Commons Standing Committee on Science and Research about Standing Order 108-3I. Drawing on my own research, I would like to share what I hope to be useful elements contributing to answer one of the 4 questions listed in this standing order, namely, what is driving an increase in antimicrobial resistance, or AMR? To do so, I would like to focus on armed conflicts. Since 2017, together with Canadian and international collaborators, I have been leading research on the interplay between AMR and armed conflicts. In 2018, I organized a symposium on this topic in Geneva, Switzerland, where the keynote address was delivered by Dr. Tedros, then and now Director General of the World Health Organization. The momentum generated by these early efforts was unfortunately interrupted by the COVID-19 pandemic. Yet the problem has not only persisted, it has worsened. The number of active armed conflicts is now at its highest level since the Second World War, with a marked concentration in low and middle-income countries where the global AMR burden is already greatest. Armed conflicts were among the first settings in which AMR was recognized as a novel phenomenon in the 1940s. Although research has since largely shifted toward peacetime civilian contexts, resistant pathogens continue to emerge and spread rapidly in war zones. This trend has intensified as warfare increasingly unfolds in densely populated urban areas, targeting civilian populations, including vulnerable groups such as children. Military operations in Iraq and Afghanistan earlier this century, the latter involving Canadian personnel, brought renewed attention to this issue after severe antibiotic-resistant infections were observed among wounded soldiers. The medical evacuation of American troops to hospitals in Germany and the United States subsequently facilitated the spread of AMR to civilian healthcare systems. The war in Ukraine has further underscored this threat, as refugee-hosting countries have reported outbreaks of drug-resistant bacteria. With accelerating urbanization, cities have increasingly become the primary theater of war. This shift has transformed not only the conduct of warfare, but also its environmental and public health consequences. Urban combat often devastates housing and critical infrastructure, as has been evident in Gaza over the past 2 years, releasing heavy metals, asbestos, petrochemicals, and other toxic substances into water and soil, exposing bacteria in these ecosystems to these toxins. Like all living organisms, bacteria are affected by such toxins and must evolve adaptive mechanisms to survive. These same mechanisms drive the emergence, persistence, and spread of AMR bacteria. Contrary to prevailing views that treat AMR in armed conflicts as a marginal topic, I contend that these environments merit close scrutiny as powerful drivers of AMR and as unique sites for studying its dynamics. Just as the Arctic stands at the front line of climate change, so too do armed conflicts represent hotspots where biological, environmental, social, and infrastructural disruptions converge to accelerate AMR. The mistake would be to assume that rising resistance in war zones remains confined to them. Emerging infections and pandemics remind us time and again that microbes respect no borders. As we enter an era of growing geopolitical tension, marked by the highest number of active conflicts since World War II and rising global military expenditures, it is imperative to address the intertwined crises of AMR and armed conflicts. Canada has a strong record of leadership in tackling global health challenges such as AMR. It is time for the Canadian government to renew that leadership by championing international efforts to make the intersection of AMR and armed conflicts a global health and security priority. I thank you for providing me with the time to contribute to the work of this committee, and I welcome questions or comments you may have. Merci.
Thank you. We will now proceed to Dr. Wright. Dr. Wright, you will have 5 minutes. Please go ahead.
So good afternoon, Madam Chair and honorable members. I'm quite grateful for the opportunity to speak to you as a Canadian academic working on the causes and solution of antibiotic resistance. I'm a professor of biochemistry and biomedical sciences at McMaster University, where I've led a research team on AMR and antibiotic discovery since 1993. I founded the Michael DeGroot Institute for Infectious Disease Research, the David Braley Center for Antibiotic Discovery, and I've advised industry, government, and not-for-profits on antibiotic innovation for 25 years. I also founded a spin-out company based on assets discovered in my lab to further develop new products. The committee's attention to AMR is both timely and essential. I was a member of the Council of Canadian Academy's 2019 expert panel on when antibiotics fail, where we found that AMR cost Canada $1.4 billion in direct healthcare expenses and caused 5,400 deaths in 2018 alone. So AMR poses an existential threat to Canadian health and prosperity. My role as an academic researcher is to uncover the molecular basis of AMR, discover potential solutions, and train the next generation of scientists. For over 32 years, I've trained more than 100 master's, PhD students, postdoctoral fellows, and technical staff. Yet very few remain in Canada or continue to work in AMR research. So why is this? The reasons are structural. Canada currently has limited biotech and pharmaceutical R&D capacity, especially in antibiotic discovery. Graduates are rather drawn abroad to vibrant biotech sectors in Boston, California, and Europe. In universities, building and sustaining an internationally competitive AMR lab in Canada is very difficult. So academic scientists work like small businesses. We have to recruit talent, we have to generate product, which in our case is high impact, internationally competitive research, and we have to fund this. And we do this through securing grants. And in Canada, this is primarily through the CIHR. It's instructive to understand how these grants are given out. So these are reviewed by volunteers in panels organized by scientific discipline. And at the CIHR, however, there is no AMR panel. Instead, AMR projects are lumped in with projects in bacterial physiology, fungal biology, and parasites. If you can contrast this to areas like cancer and cardiovascular disease, and even behavioral scientists, who enjoy multiple specialized panels, this structure disincentivizes young investigators from pursuing AMR work. So despite the global urgency, Canada risks losing academic capacity in this field. So what happens if you discover something exciting in the lab that might turn out to be a new medicine? Well, there we're very challenged as well. Decades of experience has shown that the biotech sector emerges from discoveries made in academic labs. Yet Canada lacks early stage funding mechanisms to bridge the gap between discovery and application. Programs like CARB-X that you'll hear about help internationally, but their domestic opportunities are scarce, and advancing discoveries sufficiently to be attractive to agencies such as CARB-X requires different resources. A proven model that's worth emulating, I think, is the US Small Business Innovation Research Program, the SBIR. This provides competitive, non-dilutive grants to support startups commercializing academic discoveries. A Canadian SBIR-style program would foster biotech entrepreneurship, create jobs, and accelerate AMR innovation. As an illustration, my lab recently discovered a new antibiotic, which we published in the journal Nature last spring, that targets several pathogens on Health Canada's priority list. We want to develop it in Canada, but without early stage push funding and downstream pull market incentives, these assets risk moving abroad, along with their economic benefits. So in closing, I want to urge the committee to act on two priorities. I would ask them to support an increase in overall CIHR funding and create a dedicated AMR research stream to strengthen Canada's scientific foundation in this area. And second, I believe we need to establish a Canadian SBIR-like equivalent to ensure translation of discoveries from academia to industry and to ensure Canadians benefit from homegrown innovation. I think Canada can lead in the global response to AMR and protect both our public health and our economies. Thank you very much for this opportunity.
Thank you, Dr. Wright. We will now go to Professor Kevin Outterson. Please go ahead. You will have 5 minutes for your opening remarks.
Good afternoon, Madam Chair and honorable members of the Standing Committee. My name is Kevin Outterson. I'm the Austin B. Fletcher Professor of Law at Boston University and the founding executive director of CARB-X, which is the world's largest nonprofit partnership supporting the development of treatments and vaccines and diagnostics to combat AMR. CARB-X is proud of the fact that Canada has supported CARB-X since 2023. I'm going to focus my remarks today on point 4, Canada's role in financing innovation, a complementary mix of push and pull incentives to support new antibiotics. But I have to say the first 2 witnesses have been excellent, and I support what they said as well. For more than a decade, reports around the world, including the review in AMR from the United Kingdom, official communiques of the G7 and the G20, and most recently reports from the Global AMR R&D Hub, of which Canada is a board member. All of these have emphasized the importance of combining both push and pull incentives to accelerate innovation and to fix that broken market for antibiotics. You see, in most therapeutic areas like cancer or something, the best new drugs are rapidly and widely used by doctors and patients. It leads to robust sales because people want to use the new innovative drug. But for antibiotics, we take a very different approach. We keep the best new drugs on the shelf for the first 5 to 10 years, so resistance is delayed. We prioritize preserving their precious power through stewardship. Now, this is excellent for public health. It's the right thing to do, but it drives the companies behind these drugs into bankruptcy if we only pay them based on the volume used, especially in those early years. I served as a member of the expert panel for a different Council of Canadian Academies panel, the Overcoming Resistance Report, issued 2 years ago. It built on the prior CCA report, including the one that Dr. Wright was on, and the Pan-Canadian Action Plan. And the consensus from that report is that without new incentives, the antibiotic pipeline, the innovation pipeline, remains perilously thin, and Canadians will lack access to new antibiotics worse than any other G7 country. It also concluded that both push and pull incentives are needed to restore health to this pipeline and to protect the foundations of modern medicine from assault from these bacterial infections. Now, push and pull incentives effectively address different parts of the same problem. Push incentives, like what Dr. Wright was just calling for, SBIRs in Canada, reduce the cost and risk of developing new antibiotics. CARB-X is an example, SBIRs or basic research funding are other examples. Pull incentives, on the other hand, reward successful development, something that makes it to approval, but it ensures that the companies can sustain production and support stewardship once the antibiotic reaches the market. The United Kingdom today has the best working example of a pull incentive. Both of these are essential. They work together. Now, Canada has already begun to act on this challenge at many levels, including Public Health Agency of Canada, PHAC's investment in CARB-X over the past 2 years. CARB-X is supported by 6 G7 governments, including Canada, and 3 charities. Our important role has been recognized by the G7, G20, and UN General Assembly. 22 of our supported products so far have entered human clinical trials, which is a remarkable success at this stage. We hope that our important partnership with the Canadian government continues. It's been represented by PHAC in the past, but now also we hope by the newly established Health Emergency Readiness Canada, HERC, that they will continue at a level commensurate with other G7 governments. This would be approximately Canadian $6 million per year from Canada. The U.S. government contributes about 55 million Canadian per year, Germany 15, Italy about 12. Push incentives lower the cost of R&D, but we also need the pull. They replace revenues lost because we're careful with these antibiotics in the early years, and it needs to reflect the broader social value of these antibiotics. They're necessary to keep these late-stage investors, like Dr. Skinner, we'll hear from the next panel, keep them coming into the market. Earlier this year, with colleagues, I published in a paper in one of the Lancet journals talking about the fair share gap in antimicrobial innovation. And it calls for each member of the G7 to pay their fair share of the innovation cost without free riding. Currently, only 2 countries across the EU and G7 have achieved fair share, the United Kingdom and Italy. Canada, I'm afraid to say, came in last place because the 2 drugs evaluated are not available yet in Canada. The paper calls on Canada to contribute its fair share, which I calculated in that paper to be approximately $13 million in revenue per new drug per year in Canada, out of the global total of $363 million. If we do this and continue the efforts of both push and pull, I'm confident that Canada can help to address its part in solving this global problem. Thank you.
Thank you. Thanks to all the 3 witnesses for their opening remarks. We will now proceed to our round of questioning, and we will start with first round for Mr. Baldinelli for 6 minutes. Please go ahead. You will have 6 minutes.
Thank you, Madam Chair, and I'd like to thank the witnesses for being with us this afternoon. Very interesting comments from our witnesses today, and interesting to get their comments on how we can incentivize better the work that needs to be done, particularly here in Canada. And Dr. Wright, you know, as an alum from McMaster, welcome and thank you for everything that you're doing, including the work at the Global Nexus School for Pandemic Prevention and Response. Recently, we heard from a couple of witnesses that they spoke about the concern from the Health Canada Special Access Program, and in terms of the development of the antimicrobial therapies. And they mentioned there's only 3 out of 18 new biotics launched worldwide that are available here in Canada. And the notion of what that impact is. I mean, on Monday, we had a Dr. Hamlin come forward, and she spoke that Canada's the last in the G7 in providing access to medicines in Canada. And she indicated that's all medicines. And I think that touches on some of the comments that you had made with regards to push and pull. And you had mentioned, Dr. Wright, the notion of the funding for the research side. You indicated about, you know, the work that you had done and amongst many, and the $1.4 billion. This is costing our provincial healthcare systems. Yet we're only spending $1.25 billion at the Canadian Institute of Health Research. Right now, I mean, prior to a budget coming in a couple of weeks, you know, we've heard indications from the government that they've talked to their agencies and departments asking them to find savings of 15% over the next 3 years. So dollars, precious dollars, could be limited in that capacity. And that's quite concerning, considering the fact that, you know, they're estimating a budget deficit of about $68 billion to service our debt when we're only spending $52 billion on health care. In fact, I repeated this earlier when what's more shocking is the province of Ontario spends, for a province, $80 billion, while we're only spending $52 billion for an entire country. So I'd like to get to your question, or ask a question with regards to how do we go about furthering those push incentives with regards to opening up the availability through the Canada Institute of Health Research to ensure that more research dollars flow to the AMR side as opposed to other initiatives? Because you're saying under peer review, it seems to be like the larger issues of concern such as cancer get more of the funding than, say, an AMR study would.
Well, thank you for that question, Mr. Baldinetti. And yeah, I can speak to this only in the sense that what we don't want to do is rob Peter to pay Paul, right? I think it's important to realize that this is not a zero-sum game for us. That we need to fund AMR commensurately the way that we do other really important biomedical research and clinical research problems. The So I'm not suggesting that we should allocate money away from other areas, but to support AMR. But I do think it's important for everyone to realize that we use most of our antibiotics in the hospitals to help cancer patients, for example, and to help patients who undergo, cardiovascular surgery. So AMR plays a vital role in all of these areas, and I think it's just incumbent on society as a whole to understand that this fundamental research is funded in Canada through the CIHR, and that what we want to be able to do is support that to a greater extent than what we are right now.
So any potential cuts in funding to CHIR could have health consequences down the road if that's an avenue that sees reduced funding in the next couple of years.
I think that's fair. I mean, that's where our fundamental medical research comes from, and if you cut that fundamental medical research, there will be consequences.
Indicated in your remarks about the development of a new drug, I think, or a therapy, and yet what precluded it from getting to actual development stage? Can you explain that? I remember during the COVID time period, you were also McMaster was working on a nasal vaccine, and how that development and how did that go about?
So that vaccine is currently in stage 2 clinical trials. It's still a going concern. We're very excited about those opportunities, not just for COVID, but for the delivery of many other vaccines for respiratory infections going forward. So that intellectual property and that strategy is still here with us at McMaster, and we're excited about it. With respect to some of the other challenges in making drugs, the short answer is drug discovery is very hard, and it can fall apart on many ways. And in discoveries that we've made, getting them down towards additional development is where you start to realize unexpected toxicological issues. This is why drug discovery is so expensive, right? It takes a lot of money, and it's not terribly exciting discovery science that students want to do. It's very careful analyses going forward. And that's one of the challenges that we have here. In our case, a lot of that was funded by the NIH, not CIHR, in the United States. The current drug candidate that we're trying to move forward, we're looking mostly to Europe to get funding for that, but we're also being supported by the NIH right now as well. So the CIHR funded the initial discovery, but once that discovery has been funded, there's really no mechanism in Canada to move these things forward so that we become attractive, say, to Dr. Uderson's CARB-X.
Great line.
Thank you. We will now proceed to MP Rana for 6 minutes. Please go ahead.
Thank you very much, Madam Chair, and thank you very much all the witnesses for being here with us on this Wednesday evening. Dr. Wright, you are from McMaster University, which is next to my riding. And I really appreciate the university is doing a lot in different fields, especially in Innovation Park and isotopes production around the globe. Along with that, McMaster University has developed a globally recognized program dedicated to antimicrobial resistance. What key factors contributed to the successful launch of this initiative?
So thank you for that, and thank you for highlighting that this concentration of antibiotic research it's at McMaster, which I think is unique in the country. To be perfectly honest, the way that happened was through the benefit of philanthropy. So we at McMaster have benefited from families and individuals who have given to this area, understanding that it was underfunded, understanding that there was a research gap, but that the talent and the solutions were actually here to be exploited. And so that has been game changing for us. The other part that I think is part of this story that I think is worth putting on the table, which is the absolutely transformative effect that a Canadian program called the Canadian Foundation for Innovation, the CFI, has had. The CFI is how we bring research infrastructure into our labs, into the universities across Canada. We have benefited tremendously from that. And my colleagues around the world are in envy of the CFI. And I think it's something important to recognize that we really want to maintain that, because it's really been game-changing for us to be globally competitive in this field.
Thank you very much. And David Bareilly Center, you are much familiar about it, for antibiotic discovery at McMaster University. I know this is at the forefront of Canada's fight against antimicrobial resistance. So with a focus on cutting-edge research and global collaboration, the center plays a vital role in addressing one of the most pressing health challenges of our time. So what led to the establishment of the David Bareilly Center for Antibiotic Discovery at McMaster University, and why was Hamilton the right place for it?
So this, again, was the philanthropic donation of Mr. Bareilly, who unfortunately passed a few years ago. He was a local Hamilton business person who had really wanted to invest in McMaster, understanding that we had critical opportunities here to do good things. With his help, we've been able to create a critical mass of researchers that are working on AMR and broad strokes here, as well as things like the vaccine that we talked about before, vaccination that we talked about before. So this was one of those really important roles that individuals can make in really shifting the research landscape, the scientific landscape within their communities. And folks like Mr. Bareilly and folks like the DeGroot family for us have been just absolutely game-changing.
Okay, and what do you think? How has the government support been critical in advancing the center's research on antimicrobial resistance?
Well, we've been able to leverage provincial support with some of the Bareilly money, which has been important several years ago. And as I mentioned as well, the Canadian Foundation for Innovation, there's a core laboratory at McMaster that is absolutely second to none in the world that is focused on antibiotic discovery that would not exist without the Canadian Foundation for Innovation. It's just simply a non-starter. So that's been mission critical for us.
And what are the biggest bottlenecks in antibiotic discovery, and how can we address them?
Well, the biggest ones, as I touched on in my brief, that I see, frankly, is how do we keep our brightest people here in Canada working on this problem? And can we find a way to fund the translation of discoveries that are made in the lab further down the development pathway? This is an area, as Dr. Udason told us, that where private equity is not going to be the solution, at least not in the short term. So we need some help if we're going to be able to move this forward. So keeping the talent here is mission critical, and finding a way to keep the funding going is critical.
Thank you very much. And Mr. Kevin Utterson, how important is international coordination for tackling AMR?
This is not a problem that any one country, even wealthy G7 countries, can do on their own. It requires international work because none of us are capable of doing it by ourselves. If we're going to do a pull incentive, it makes no sense for the United Kingdom to do it by themselves, even though they've done an excellent job. It won't have impact unless the rest of Europe and the rest of the G7 and eventually the US joins. And if I could mention just international cooperation with Dr. Wright. I've been to McMaster several times. I've been their guest for a day in which there was a lecture series. I know the world-class scientists that they have there. Their source of funding is, in addition to Canada, is obviously the US NIH, European sources, and I hope that Dr. Wright's new molecule from the cover, from Nature recently applies to Carbex in the near future. But, these things, in order to work, he's identified that this lack of a SBIR in Canada, most US applicants and many European applicants have received a couple $100,000 after they've spun out in order to get their data lined up for such an application to something like us. We're a charity. We don't take equity, but we require certain amounts of data. And it's hard to do that without this extra translational device called an SBIR in the US. And it goes by a different name.
Sorry for interrupting. Time is up, Mr. MP Rana. For you, we will now proceed to MP Blanchet-Jonca. Please go ahead. You will have 6 minutes.
Merci, Madame la Présidente. Je salue les témoins qui sont avec nous aujourd'hui. Mes premières questions vont être pour Dr. Araoui. Vous avez fait le lien entre les guerres modernes et la propagation d'organismes biorésistants jusqu'à chez nous. Or, les mouvements migratoires qui découlent de ces conflits, qu'il s'agisse militaires, de
Sorry for
travailleurs...
interrupting. There is no translation, so we'll stop.
Interpretation is on. Let's go. Okay, I'll start from the beginning, Madam Chair. I advise the colleagues that my time is rolling. Thank you, Madam Chair. We'll have a first doctor for Dr. Hawaii. You indicated that the anti-DARM is often spreads throughout the country, including in Canada, due to conflicts. And Canada is welcoming the largest number of refugees and asylum seekers in the whole country. Now, it's the first line, if you will, of resistance against ARM in Canada. Well, thank you for your question. In fact, you're quite correct in saying there is an association between population migration and the propagation of resistant pathogens. We want to avoid stigmatizing any sector of the population, of course, in how we deal with the basic issue. We're trying to minimize the consequences that are suffered by these populations. They are coming here seeking asylum for a reason. We also have protocols in place, certainly in Canada as well as Quebec. Our tracing and tracking methods have improved. People are hospitalized. They're checked out to see if they are vectors or carriers of these pathogens. My comments was to complement what Dr. Wright was saying. Renowned researcher, and we appreciate his work and his successes. Our request is to solve a problem. And what I was trying to explain is that there's a lot of preventive measures that could be taken to prevent any increase in resistancy of these pathogens or bacteria. I can give you an example of a project which was funded by a Canadian organization, the Grand Challenges Canada, where we developed a telemicrobiology system. We were able to have the participation of Syrians or others who are trained abroad who could help people who are struck by these bacteria. They occurred, the phenomenon of this presence is mostly in low and middle income countries and weak health systems. But particularly in conflict zones, the conditions, the environment is perfect for the spread of these ARMs. Thank you for sharing that. And Canada should show some leadership in ARM research. We had a witness recently before the committee which recognized that we have no particular program. Canada has reduced its investments in R&D, the only G7 country to do so over the last 20 years. So it's not really surprising that there's been a slowdown in research and development. Well, I think Dr. Wright explained that quite well. Significant research is made in Canada, and there are some stages or phases of research which are completely lacking. There are gaps. collectively, these presentations this afternoon seeks to enhance that leadership or encourage that leadership. It's not a situation or a solution that can be found by one country alone. It has to be much wider than that. Canada used to have that leadership role, but unfortunately, that leadership role is lacking today. We would encourage government and the authorities that the establishments and institutions be created or be supported to accelerate international cooperation to solve some critical issues. You did notice that there's a lack, an absence of these research, but none specifically for ARM research. Now, that's fairly illogical because today the Minister of Industry, which is responsible for the tri-agency funders, that we should continue to be at the in the forefront of this research and maintain our competitiveness in a research environment which is very competitive. So you talked to me about our advanced status and then again about the brain drain from Canada. It's very difficult to reconcile the two. I'll answer in English if I may. Be easier for me.
Short answer is certainly in certain parts of research we are world leading, and in fact we are, and I would argue, that the labs around the country that do work on antibiotic resistance are lean, mean fighting machines that are internationally competitive because it's just a small community. And so my point here is really that what we need to be able to do is make sure that we have the resources specifically for this area that I think we can all agree isn't.
Sorry for interrupting, Dr. Wright. Time is up. If you can just quickly wind up, like 4 or 5 seconds, if you want to wind up.
Yeah, just to finish up, and it's a good question, but I think it's really just a matter of density in this case of individuals.
Thank you. We will now proceed to MP Mahal for 5 minutes. MP Mahal, please go ahead.
Thank you, Madam Chair, and thank you to all the panelists and all the witnesses who spared their time and come to this testimony, important testimony. I would start with Dr. Wright. Dr. Wright, you stated in your testimony that the AMR is next existential threat to Canada and to the world. And we have seen mismanagement during COVID and during other times where the money was spent on things that were not necessarily helping out the Canadians the way they should have helped. So my question to you is, do you think Health Canada is doing enough to get medication approved for AMR and microbial resistance drugs? And how fast is it? Is it fast enough, or are there delays?
Well, I thank you for that question, and I think the evidence speaks for itself, right? Out of the and I'm going to get the number wrong because it used to be in front of me, whatever it is, 15 new antibiotic entities that have been brought to market over the last 10 years. We have access to only 3, so I think that's not a great ratio. So there's a number of reasons for that. I think one of them we do have to remember, and that is that Canada is a very small market for these drug companies, and so the barriers to entry for bringing a new or an antibiotic that has received approval, say for example, by the FDA or the EMA and into Health Canada, requires some bureaucracy, and that bureaucracy, I think, has to be measured against the potential market size in Canada and the distribution across this great vast country. So that is part of the issue that's being faced. I think, of course, what we want to be able to do is ensure that all the barriers to getting these medicines to Canadians are reasonably removed, so that we're not artificially stacking the cards against ourselves.
Thank you. Thanks for the answer. I think that very well talks about the difficulties that you as developers, as scientists face when it comes to federal funding, when it comes to bureaucracy, when it comes to red tape. That has always been the case from last 10 years when it comes to making funds available for these vital research. So do you believe enough of federal dollars are being pushed to CIHR for AMR-related drugs in that context?
The short answer is no. I think we need to be able to do more. If we want to be competitive, if we want to pull our weight, as Dr. Uderson said, on an international stage, we have to invest more.
Thank you. How do we compare Canada's federal funding on AMR and those bacterial researches, those are in the face of real crisis that can come, God forbid, anytime, at any point that we are talking about. So how critical do you think Canada is in regards to if we have to draw a comparison with other jurisdictions?
Yeah, so there's certainly most of the G7 countries fund research as a percentage of GDP much better than Canada does. I don't have the numbers at my fingertips to be able to tell you what percentage goes to AMR research in all these different countries. But there's a lot more AMR researchers outside of Canada than inside of Canada.
Thank you so much. Thank you. And during your testimony to the question of one of my other colleagues, you did share a pain of young Canadian scientists who would face, if they do not, as the system is right now, where the funding is so tough, where the red tape is so tough, the approval, getting to the market is nearly impossible. You say that they would likely find other markets to explore. So how do you feel to that when you train those scientists and they are not able to serve the Canadians that they have taken their education from, that they have taken their funds from? How do you want to reply to that concern that he shared?
That's the reason why I'm testifying today, because one of my major roles, as I indicated, is to train the scientists of the future, and I would love to see them having successful careers here in Canada, and I would love to see them having continuing the work in this field that we've trained them in. So they're doing outstanding work as they're being trained, and we are internationally competitive, in especially the labs at McMaster. But it is heartbreaking to see that
time
talent
is up. Can you
migrate
please
into
quickly
places.
wind up?
Yeah, I'm done. Thank you.
Okay, thank you. We will now proceed to MP Jessic for 5 minutes. Please go ahead.
Well, thank you so much, Madam Chair. And again, thank you to all the witnesses. And you're not quite done, Dr. Wright, because my first question is for you. We've heard a lot about your requests and some of your strong feelings related to funding. But I'd like to go back a little bit more to the process of approval. Your institute is developing new products. We have heard during the course of this study some criticisms of the length of time that Health Canada takes, the Canadian Drug Agency as well, in terms of approval of new medications in general. And given your experience, could you give us any recommendations as to how perhaps the process might be speeded up?
Well, I'm a fundamental researcher in a university, so I haven't had the opportunity to face the Health Canada challenges in getting drugs approved. I have been obviously involved in this field for a really long time, and I understand that there are significant barriers to make these things happen. And as I said, because Canada is such a small market for the companies that do have these antibiotics to sell, I think there needs to be some recognition of that and some way to incentivize. And I don't know how that is, to be perfectly honest. There's some way to incentivize the Health Canada to be able to recognize that these are challenging. It's a challenging clinical area that requires solutions, and that there's a really significant need going forward. So I think that now's the time for us to figure out how to streamline this.
Thank you. Professor Outerson, perhaps with your knowledge of what happens globally and in various G7 countries in terms of drug approval, is it just a financial issue, or is there process issues that we could learn from other jurisdictions in terms of approvals?
The regulatory authorities talk together a lot, FDA and EMA and Health Canada. They do coordinate. I was the author of that paper that Dr. Wright mentioned about how Canada is last within the G7 in actual approvals of these drugs. I don't think that the primary problem is the bureaucracy within Canada. I think the primary problem is that the price is low compared to the size of Canada, and so it's not an attractive enough market for the company to go to the trouble of doing that. So a lot of these failure to get approvals in Canada are because no one tried, because the market's too small. If Canada had a pull incentive, at the levels I've described, I guarantee you that every company would come to Canada and the rest of the G7 with that as the carrot for them to bother with the registration.
So perhaps you could describe this pull incentive a little bit more clearly. How would it be allocated? How do you see this working in terms of multiple companies perhaps competing? Just describe this, perhaps.
The shortest answer is that the Overcoming Resistance report issued by CCA 2 years ago describes this all in great detail. I was one of the 10 co-authors of that report. But it would be a revenue guarantee. So Canada would say, if you come to Canada, you will receive at least $13 million per year for this drug for making it available, practically available here. And in the first year, maybe there's small sales. By year 6, the projections are that the sales in Canada would exceed that number. So the revenue guarantee wouldn't cost the federal government any money whatsoever. It's a federal guarantee. The drug is still available and used in the provinces and territories, and it's paid for in the ordinary way that it happens in those areas. And it's my understanding that the government is working now on a pilot to operationalize this, but the details of that are not known to me. But it's been underway for some time since the CCA report.
So perhaps would this be administered through this, would you have any idea which organization within government would administer this type of pull incentive?
It's my understanding it'll be at the federal level within Canada, but I do not know which agency. It's not been announced that the pilot is public yet. So someone surely in Ottawa knows. It's just not me.
12 seconds. Okay. Thank you, MP Jacek. We will now proceed to MP Blanchet-Juncker for 2.5 minutes. Please go ahead.
Prochaine question pour M. Utterson. Vos travaux
My next question for Mr. Overson. You indicate that it would cost millions or even billions of costs to the global economy. Now, we might even Canada is trying to act even during these hard times. And do you have any concrete estimate at what an efficient investment plan would cost as compared to the consequences if it's not achieved? Mr. Utterson.
Given that it's likely to not be needed after 5 years. And that's $13 million of a guarantee, but really only about half of that would be spent on average per year. For CARB-X, we've asked Canada for something in the range of 6 million Canadian per year, and that would cover our pull incentive, which we provide charitable, non-dilutive help to companies worldwide, taking them from the hit to lead stage to the end of the first in human. The proposal from Dr. Wright, 2 of them I can think of. One is to create a specific committee within CIHR which funds AMR and increasing that. And then the second one was his request for something like an SBIR, and really that's less than $1 million or $2 million per year, because these awards are typically $200,000 to $300,000 US, and there's not that many companies that actually would use them. Together, that's a pretty comprehensive program. It would guarantee Canadians research continuing going forward and make sure that these new drugs are actually practically available in Canada without financial barriers to the patients.
Merci. Dr. Wright, je vais vers vous. Des solutions concrètes pour garder les talents.
Concrete measures should be taken here in Canada to avoid the brain drain that you mentioned. What would you suggest?
Case, actually, what we need to be able to do is have sufficient resources so that people can have careers here. So whether those are in the academic sector or whether that's in the biotech or pharma sector, people just want to lead their lives and bring up their families, and they need to be employed for that, and that's what's needed.
Thank you. We will now proceed to MP Holman for 5 minutes. Please go ahead.
Thank you, Madam Chair, and thank you to all the members, all the members of the committee, including the witnesses coming out here on a busy Wednesday night. Recently, Parliamentary Budget Office report concluded that the projection that the government's borrowing requirements will begin to exceed the maximum amount in 2026-2027 as the debt crosses the 2 trillion mark. The PBO bluntly told Canadians the government will need to make choices to either raise revenues or cut spending in order to stop this unsustainable path that we're on. Already, the Liberals are spending more on interest payments for their debt than on health care. AMR is a related healthcare issue. Cutting health costs will cause concerns for the spread of AMR, especially in neighborhood health centers and also possibly in hospitals. My question is for Mr. Wright. You mentioned in your briefing that Canada does not have AMR labs or research. There's no AMR panel. It's bungled in with fungal and pesticide research. Canada risks losing academic talent, research in AMR. Canada lacks early stage research. May you please expand on that?
Yeah, sure. Let me just qualify that by saying we have some outstanding AMR researchers across the country. Lots at McMaster, but you're going to hear from some from McGill in the second panel. So there is an excellent group of cadre of individuals who are working in this area. What is a reality is that we are challenged to keep new young investigators here who are going to find the solutions of the future. This is how it's how science works. It's the young people who drive it. And we need to keep that talent here. So what I'm suggesting is that for not a lot of money, you could maintain the excellence that we have. You could expand on it, and then in particular, I'm extremely committed to ensuring that discoveries get translated into solutions for Canadians, and that the translation is a huge gap that's missing here in Canada, and it's something I think that could benefit not just AMR, but all other fields of biotechnology as well.
Okay, thank you, sir. With regards to Mr. Oderson, you mentioned in your introduction that with CARVEX, Canada's role of opportunity to research AMR, reports of global AMR research, Canada is on this panel. You mentioned with regards to fair share, I understand fair share funding, only 2 countries from the G7 do this completely. It's the United Kingdom and Italy. With Canada's lack of funding, is this a cause for concern of solving the global problem with regards to AMR?
Canada's economy is about 3.5 or 4% of the G7, G7 plus the European Union, and so you're a small but important part of that. If Canada chooses not to do a pull incentive, and the rest of the G7 does, the innovation solution will probably be achieved, but the drugs will not be available in Canada. So for a relatively small amount of money done collectively with other G7 partners, there can be a great solution. One other thing I'd like to say, Mr. Holman, is that we have to remember that this saves a lot of money. If we don't address AMR, every surgery becomes more dangerous and more risky. Every cesarean section, every hip and knee replacement, every cancer treatment. The number 2 cause of death for cancer is infection, not cancer, number 2. So this is an investment in saving money going forward. I understand the budget issues are difficult, but this is an area in which prevention is really remarkably cost effective. Thank you.
Follow-up question to you, Mr. Adderson. You mentioned that Canada is a small market for AMR drugs, but there are smaller countries in Europe that are you implying they're more profitable? And is Canada a smaller market? Is this due to lack of funding from Canada, or possibly also bureaucracy from within Canada?
So within Europe, there are many countries that are much smaller than Canada. It is a unified market, and Europe is working right now on a pull incentive for all of Europe. It should be announced in November next month in Denmark under the presidency of the European Council. So that they are also working on this and are trying to make sure that there's access to the smaller countries of Europe, in addition to major markets like Germany.
Thank you. We will end this panel with MP Rana for 5 minutes. Please go ahead.
Thank you, Madam Chair. And sorry, Dr. Wright, you are not done yet. So my question is to you. You have been working with lots of grant panels and consultants. So based on your experience, what do you think the funding for AMR research change over time?
So, I can give you a concrete example of this. There was a significant investment in AMR and bacterial diseases funding in the 1990s and early 2000s through something called the Canadian Bacterial Diseases Network, which was part of an investment in several network centers of excellence, which were dedicated to certain disease areas or in areas of biotechnology development in partnership with small and large businesses. This was game-changing for a lot of folks like me who were trying to build up their careers at this time. And that program unfortunately sunsetted in the mid-2000s, leaving only the CIHR to be able to make up that change. So there's not a lot of other opportunities out there right now, and that's where our challenges lies.
Mm-hmm. Thank you. And with respect to government funding, what policy or structural changes would you recommend to better support AMR research and antibiotic development in Canada or globally?
And I think you've heard a lot of them today. I think my interest would be to fund both the front end, which would be to make sure we invest more in the early stage investigations, fundamental research and discoveries through places like CIHR. I think that an SBIR-like program would help us push some of these discoveries out of the lab and make us competitive for agencies like CARB-X that Dr. Uderson runs and Canada supports financially. So that ecosystem has an opportunity to be fleshed out, and I think that would be optimal for the country and for the health of the Canadians going forward.
Thank you. And where do you think we are doing well, and where we have to improve in AMR research?
Well, honestly, we're quite fortunate. We have an outstanding public health service here who are working tirelessly in areas like surveillance, who are trying to really make sure that we're staying on top of AMR in hospitals and on farms. So that area we're doing quite well in. We're doing very well in fundamental discovery-based work. We're punching well above our weight, I think, in that area, despite the challenges that we face. Where we're falling down is in moving those discoveries out of the lab and trying to do more and develop a biotech sector around infectious disease that I think will actually help move the needle in this field.
between government, industry, and researchers play in advancing AMR research in Canada?
I'm sorry, Mr. Wright, was that directed at me or at someone else?
Yeah, it's direct to you, Dr. Wright.
Okay, thank you.
Yeah,
Sorry,
yeah,
I missed
no
that. The microphone cut out.
No problem.
Sorry, can you say it again? I'm sorry, without eating into your time.
Yeah, my question was in between like a government, industry, and researchers. Are they playing any advancing in AMR research? Any role?
So certainly government is. I mean, one of the challenges in this field, which has changed dramatically since I entered it in the early 1990s, is that the large pharmaceutical industries have abandoned this field. The people that used to make the drugs in this field, the Mercks, the Pfizers of the world, are not in this business for all the reasons that you've heard before. The return on investment is too low. That means we must, as society, invest in this area if we're going to prevent the challenges that Dr. Udison just noticed, which is to have every medical intervention be more dangerous than it needs to be.
You think working well or not so well?
I'm sorry, the mic cut out again for me.
I'm asking about any collaboration models that between government, industry, and private partnerships.
So there's great examples of this in a number of areas where governments and industries have come together to each bring in capital to the project and to be able to move things forward in areas such as vaccinology and some areas of drug development. We've seen this in manufacturing, for example. So there's good reason to think that we could do the same in this field. Again, I just want to caution that one of our challenges again in this field is that large pharmaceutical companies that we used to see as sort of being able to help fund some of these programs are just simply not in this field anymore.
Thank you very much, Dr. Wright, and we'll see you soon at McMaster University. I already been 3 times over there, so we'll see you soon over there. Thank you.
We look forward to seeing you.
Yeah,
thank you. With this, this panel comes to an end. I really want to thank all the witnesses for coming today and providing your important testimony for this study. So with that, this panel will come to an end, and I will suspend the meeting for a few minutes so that the witnesses for the second panel can take it. Thank you once again. The meeting is suspended. For the benefit of the new witnesses for this second panel, welcome to all the witnesses for this panel. Thanks a lot for appearing before the committee. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you are not speaking. For those on Zoom, at the bottom of your screen, you can do the selection for the appropriate channel for interpretation, either floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed to the chair. For this panel, we are joined today by Dr. Henry Skinner, Chief Executive Officer of AMR Action Fund GP, by video conference. We are also joined by Dean's Council for Agriculture, Food, and Veterinary Medicine, and they are being represented by Dr. Joseph Rubin, Professor, Department of Veterinary Microbiology, Western College of Veterinary Medicine, by video conference. Also being represented by Dr. Maud D. Lagarde, Assistant Professor, Faculty of Veterinary Medicine, Université de Montréal, also by video conference. And our third witness for this panel is Dr. Diao Nguyen, Founder and Director for McGill AMR Center, also by video conference. So welcome to all of the witnesses. Thanks a lot for coming and appearing before the committee. All of you will have like 5 minutes for your opening remarks, and then we will go into round of questioning. And we will begin with Dr. Skinner. Please go ahead. You have 5 minutes for your opening remarks. Thank you.
Thank you. I want to thank the Standing Committee on Science and Research for inviting me to testify today. My name is Henry Skinner. I'm a microbiologist, life science investor, and the CEO of the AMR Action Fund. The AMR Action Fund is the world's largest venture capital fund solely dedicated to late-stage antimicrobial research and development. It was created in 2020 through a collaboration between the pharmaceutical industry and philanthropic organizations like the Wellcome Trust, which recognize that AMR is a fast-moving threat that imperils the health of everyone and could cost the global economy trillions of dollars. My fund is trying to mitigate this threat and protect patients by investing in small and mid-sized companies that are developing urgently needed therapeutics for the most dangerous drug-resistant bacteria and fungi, what the WHO and CDC call priority pathogens. I've been investing in biotechnology companies for 25 years, and the decline in investment and innovation in the field of antibiotics is alarming. Like most venture capital funds, we are structured to exist for approximately 10 years, which we hope is enough time for policymakers around the world to enact appropriately sized incentives and correct the market failures that makes discovering and developing new antimicrobial treatments nearly impossible, as highlighted by the Council of Canadian Academics report in September of 2023. We focus our investments on biotechnology companies that are conducting clinical trials in humans to test for safety and efficacy, the stage of drug development where costs are highest and the need for external funding is most acute. While the fund has approximately $1 billion US under management, a single clinical trial can cost several $100 million, so we must be extremely selective in our investments. Our goal is to bring 2 to 4 novel antimicrobials to market by 2030. So far, we've made 12 investments and obtained 1 antibiotic approval. To date, however, we've not invested in any Canadian companies, and that's not a reflection of Canadian innovation. In fact, there are some promising R&D programs across the country, especially in the earlier stages, with labs leveraging machine learning and AI to aid antibiotic discovery efforts. But all antimicrobial developers, whether they're based in Edmonton, Boston, or Lyon, are up against extraordinary market challenges that make it exceedingly difficult to attract investors. In all other therapeutic areas, the market rewards innovation through sales volume, meaning delivering cholesterol pills, cancer medicines, or obesity shots to every patient that could benefit. But due to the way bacteria and fungi evolve, clinicians are instructed to use new antimicrobials only when absolutely necessary in order to preserve the drug's effectiveness and hope that resistance takes longer to build. This is necessary for public health, but it makes it exceedingly difficult for investors and companies to justify spending money on antibiotic research and development. Antibiotics are not blockbusters. Sales of the top 10 antibacterial products don't even add up to $1 billion. In comparison, a single cancer drug can generate more than $20 billion in sales in a single year. Antibiotic research and development is incompatible with the fiduciary responsibilities of private investors who need to generate returns. Each year, venture funds invest tens of billions of dollars into biotech companies, but less than 0.01% of that money is invested in companies developing antibiotics. This represents a classic tragedy of the commons, which only government policy, including Canada, can address, and will at the same time make their biotechnology sectors more attractive to private investors. Policies known as pull incentives can change how antibiotics are valued and reimbursed, and can reward companies that take the risk and are successful in developing new, urgently needed antibiotics for patients in need. Pull incentives have been successfully piloted in England over the last several years for 2 novel antibiotics, and a permanent program will now cover more antibiotics and expand across the United Kingdom. As Italy finished its G7 presidency last year, the Italian Senate authorized the use of up to 100 million euros for higher reimbursement of innovative antibiotics. To date, 8 medicines are included in that program. But a pull incentive in the United Kingdom or Italy alone is not sufficient to attract investment in antibiotic drug developers. The programs in the UK and Italy must be joined by other G7 markets like the US, Japan, and Canada, as well as the entire European Union. Only then will pull incentives reach the size necessary to assure investors and drug developers that antibiotics are a financially viable field of medicine. As you know, the government in Canada's 2023 budget, Canada committed to develop a pilot program to secure access to new antimicrobials for the people of Canada. It is important that the government of Canada move this forward and make a financial commitment that truly rewards innovation. By valuing these new projects appropriately, the program would encounter greater participation in the pilot and lay the groundwork for a sustainable national program. Canada has a moral responsibility to contribute its fair share as a G7 member and high-income country. I feel about the same about Japan's inadequate pilot program. I believe the design of the pilot should address barriers at the hospital level in providing access to new and newer antimicrobials, taking pressure off the hospital budget, coupled with the appropriate stewardship protocols, which would ensure the program will succeed in getting the right drug.
Dr. Skinner, if you can please wind up quickly.
To the right patient at the right time. And effective antibiotics are essential to a functional, efficient healthcare system in each province and territory. When used appropriately, they enable and reduce the cost of providing high-quality healthcare. Thank you very much for inviting me to testify, and I look forward to answering your questions.
Thank you, Dr. Skinner. We will now proceed to Dr. Rubin. Dr. Rubin, you will have 5 minutes for your opening remarks. Please go ahead.
Good afternoon, Madam Chair. I'd like to thank the committee for the opportunity to testify and share my perspective. My name is Joe Rubin. I'm a veterinarian, microbiologist, and a professor in the Department of Veterinary Microbiology at the University of Saskatchewan. I've been working on antimicrobial resistance, primarily in companion animals and food products, for nearly 20 years. My current roles are as an educator of veterinary students in the areas of bacteriology and infectious diseases, and as a researcher where I study the problem of AMR from a number of perspectives. There are 3 areas that I'd like to highlight today where I can see a need for additional support. First, research into evidence-based antimicrobial stewardship for companion animals. Second, support for global collaborations to tackle resistance in low and middle-income countries. And 3, support to harmonize diagnostic testing in veterinary labs with the goal of improving both passive surveillance and antimicrobial stewardship. With respect to the first topic, the committee has heard testimony about the importance of stewardship to improve how and when antimicrobials are used so that we can preserve their efficacy. Antimicrobial stewardship necessarily looks different in each context where it's applied. What might work in a large human hospital may or may not be appropriate in the diverse environments or for the patient populations that veterinarians care for. An individually owned dog is quite different from a dairy cow, a barn full of broiler chickens, or a hive of bees, and the stewardship approach to each of those situations is necessarily different. In veterinary medicine, more data is needed to support stewardship in companion animal practice. The goal of stewardship is to change prescriber behaviors, and this is quite a difficult thing to do. For companion animal practitioners, we've largely relied on passive antimicrobial stewardship, which essentially consists of providing knowledge and information through continuing education conferences and workshops. In the context of human infectious diseases, we know that more active approaches have a bigger impact on prescriber behaviors. Furthermore, there are areas where we lack data to inform how antimicrobial use can be optimized. For instance, reducing the duration of therapy can greatly impact the amount of antimicrobial that an individual animal is treated with, and at a population level, this can multiply to be a big difference. With respect to the second topic, the committee has heard that AMR does not respect borders and that the threat of resistance is global. Through international travel and trade, resistant bacteria and resistance genes can be easily transported intercontinentally. It's therefore in our best interest to assist low and middle income countries to build regulatory, diagnostic, and stewardship capacity in the veterinary and human health sectors. Meeting the threat of resistance where it's most rapidly emerging will not only protect Canadians, but also reduce the burden of resistance on vulnerable individuals, such as small-scale sustenance farmers, who may be disproportionately impacted. Finally, in Canada, there are improvements that should be made in veterinary diagnostic microbiology. While our domestic diagnostic labs are doing a good job in providing services to veterinarians, there are changes which could be made that would have both surveillance and stewardship benefits. First, national harmonization of the antimicrobial susceptibility test methods used will ensure that all of the data these labs generate as part of their routine work can be directly compared across the country, facilitating passive resistance surveillance. Second, developing a harmonized strategy for how lab results are reported would advance stewardship goals. For instance, including relevant data from current treatment guidelines, such as the veterinary first line application that was mentioned previously, along with lab reports that go to prescribers, would provide additional context to help veterinarians optimize their therapy. So to conclude, as other witnesses have testified, antimicrobial stewardship is essential in our fight against AMR. In companion animals, more resources, including grants, are needed to support the development of effective strategies to help veterinarians optimize their use of antimicrobials and ensure that current best practices are implemented. Second, we must take a global perspective and work with our colleagues internationally to combat the emergence of resistance in low and middle income countries. And finally, I suggest providing support to develop harmonized susceptibility testing and reporting protocols amongst Canada's veterinary diagnostic labs. Thank you very much for this opportunity.
Thank you, Dr. Rubin. We will now proceed to Dr. Nigwa. Please go ahead. You will have 5 minutes for your opening remarks.
Did you just call me? Sorry, I did not hear my name correctly.
You'll have 5 minutes for your opening remarks.
Okay. Good evening, Madam Chair and members of the Committee of Science and Research. I'd like to thank you for the opportunity to testify to you today. My name is Down Nguyen, and I speak to you as a physician working at McGill University's teaching hospital, as a professor of medicine and microbiology research who studies difficult-to-treat bacterial infections, and last, as the founding director of the McGill AMR Center and a new AMR Quebec network, where I lead the efforts to structure and mobilize a diverse ecosystem of over 150 academic researchers at McGill University and across Quebec, with government, public, and private partners across the human, animal, and environmental health sectors in Quebec. So first, I would like to paint a brief picture of what AMR looks like through the lens of a physician. I'd like you to imagine that a loved one who is diagnosed with cancer, which is curable but requires chemotherapy. And during chemotherapy, which significantly weakens one's immune system, you develop a fever, a typical sign of infection, and for this, you're immediately prescribed antibiotics, for which I might do tests to figure out what kind of infections you have. And if the infection is caused by bacteria not resistant, the antibiotic prescribed will likely work, and this will take a few days of antibiotics and no one will think twice about it. However, if you have an infection caused by a drug-resistant bacteria, particularly one resistant to carbapenem, a powerful antibiotic that is considered a last resort one, then the initial antibiotics will not work. And with the current diagnostic tests at hand, this may take 3 to 5 days to get an answer, if at all, about what microbes cause the infection and whether the microbes are drug-resistant. And during this time, the infection can overwhelm the body with the risk of dying increasing upwards of 50% or more, and treatments that are more toxic and complicated if available at all. So now this scenario could happen to any patients who get surgery, a pacemaker, a pneumonia, or suffer a wound. And all of these important medical interventions carry a risk of infections, complications, and could be jeopardized if prevention or treatment of infections were no longer effective. And at best, this means an average of 1 week longer hospital stay for each case of infection. And at worst, this means risky and unsuccessful procedures and treatments or deaths for countless conditions from hip replacements to cancer. So now the rates of these carbapenem-resistant bacteria, that is the resistance of last resort antibiotic, have already reached 70 to 80% in certain regions of the world today as we speak. And in Canada, the rates are much lower, but the trends are alarming, rates up to 10-fold higher in the last 15 years. And so the AMR crisis is knocking at our door, and we're not equipped to this. To respond to this, we direly need innovative solutions. We need new treatments to deal with the drug-resistant bacteria. We need diagnostic tests that are much faster and accessible to know when we're dealing with drug infections, what antibiotic to use, and we need surveillance systems that are more comprehensive and timely. And to get there, research and innovation done in collaborative manner are essential to the solutions to address AMR crisis. This is recognized by the Pan-Canadian Action Plan and numerous national action plans globally and reports, including the WHO. And where does research and innovation largely come from? Academia. With its community of researchers and teachers, we're a major asset and an important part of the solution. First, academic research is a critical source of innovation. For example, McGill ranks first in North America as a university that has launched the greatest number of research-based startup companies. In 2023 alone, there were 28 companies, most of them in the life science and medical technologies sector. This speaks to the potential for AMR, but the research and development ecosystem in Canada to nurture early discoveries are largely lacking, as you have already heard from Professor Wright earlier this afternoon. Beyond Canada, we know that academic inventions and founders are responsible for more than a quarter of all medicines approved in the last 20 years, with trend going upwards in the last 10 years. And for certain medical conditions, this represents over 80% of treatment. Second, as a researcher myself and one who interacts and mobilizes hundreds of my colleagues around AMR, academic research in Canada has notable strengths and existing initiatives upon which we need to build on. For example, in Quebec, MILA, a world-class AI institute founded by Professor Yoshua Bengio, who many of you may know as the grandfather of deep learning in AI, has an incubator that has launched over 50 startup companies and projects that bring AI tools to antibiotic discovery. And last, academic communities are important conduits to mobilize and structure the AMR ecosystem. Our experience with the AMR Quebec network is a good start and an example. So what do we need now? We need to build and support an AMR ecosystem that integrates academic research and innovation with government and public stakeholders, industry, and end users. And to get this, we need strong leadership, a person, an entity dedicated to AMR with a specific mandate to mobilize political will and resources and to coordinate activities across sectors and jurisdiction. Somebody who is heard by both decision makers nationwide and professionals. We need a government structure to organize this AMR ecosystem, and we need resources commensurate to the problem of AMR.
Sorry for interrupting. Your time is up. We'll now proceed to our round of questioning. And you can always answer and bring your points forward in the questions, in the round of questioning also. So we will now start our first round with Mr. Baldinelli for 6 minutes. Please go ahead.
Thank you, Madam Chair. And before I go to my questioning, I just want to place the following motion on notice, and it deals with artificial intelligence and goes to the government's announcement from September when it launched the AI Strategy Task Force and the consultations that are taking place this month, and then the task force is supposed to be sharing some of those bold ideas they had gathered in November. So I want to table this motion and notice motion that pursuant to Standing Order 1083, the Standing Committee on Science and Research undertake a study of no less than 4 meetings on the federal government's approach to artificial intelligence, considering the committee's mandate to study matters related to science and research which includes AI technology, and that the committee invites the Minister of Artificial Intelligence and Digital Innovation to appear for one meeting for no less than 2 hours, federal officials from the Department of Innovation, Science and Economic Development Canada, a range of AI industry representatives and experts, and that the committee report its findings and recommendations to the House. And Madam Chair, we've sent that notice motion to the clerk. Thank you. And that will be shared with all the colleagues. So thank you for that. And with that, if I could take, and I'll begin my line of questioning. And I'll start with, is it Dr. Skinner? Thank you for your comments. Quite illuminating in a sense. I had seen some of your comments. You talked about AMR now kills nearly 1.3 million people a year. We've had other panelists appear and talking about the cost of the provincial healthcare systems at about $1.4 billion a year. We've heard from other panelists again and witnesses talking about the difficulties here to get therapies to market. The notion that the Health Canada Special Access Program, and in terms of antimicrobial therapies, mentioned that there's only 3 out of 18 new antibiotics launched worldwide are available here in Canada. So I want to get to some of what your comments were, and I feel right near the end of your comments you were running out of time. You were talking about the 2023 pilot program and moving this forward, and the notion of everyone's been talking today about the push and pull incentives, and you had talked about real incentives and barriers at the hospital level. I just wonder if you could expand on that, please.
Happy to. So I think our work is supporting biotechnology companies that are bringing these important medicines to patients or trying to. There's been a number of them that have gone bankrupt. They have raised hundreds of millions of dollars, approaching $1 billion, brought the drug to successful through clinical trials and to approval, only to go bankrupt because they couldn't afford to keep the lights on after the drug was approved. That's how difficult this market is. That's how challenging it is. And we're not even talking what it costs to then expand into other jurisdictions. So to get approval in the U.S., may be a first step. To then get approval in Canada, to get approval in other jurisdictions is absolutely necessary to bring it to patients where the need is, and yet the companies don't have the resources to do that. This has become so challenging that other investors simply refuse to consider investing in this field anymore. We've heard that large pharmaceutical companies have left the field, and that has created a whole series of challenges in supporting innovation here. And all those things conspire to keep these needed drugs out of the innovation pipeline and unavailable to patients around the world. And if we don't create these pull incentives so that there's a market to keep the drugs available once they've been approved, they simply won't be any more coming.
Thank you. I'd like to go on with Dr. Nagayan. And you spoke in your remarks right at the end of your remarks about creating the AMR ecosystem that's required. I remember going back to, I think it was during our first meeting, and just from our briefing notes that the analysts had prepared, they talked about 14 departments and agencies working on the whole AMR side, and the notion that, I mean, just from a bureaucratic standpoint, 14 departments and agencies all having a voice and trying to provide input. But as part of that ecosystem, too, like how do we address that? But also to Dr. Wright, if you had an opportunity to hear some of his testimony earlier, I found it quite enlightening about his two really asks to government about we need to develop a way to keep our talent in Canada. And then that notion of how do we then have a translation of discovery that's done here to downstream implementation. So I was just wondering if you could follow up and just expand on your comments about this notion of creating this ecosystem.
So you've pointed on the ecosystem being incredibly complex, not only in terms of the departments and the agencies, but also the jurisdiction. And so above and beyond that, I think that one of the consensus that has come through our work with stakeholders is that one of the key things that's lacking is a strong leadership, a leadership that transcends agencies, that transcends sectors, to try to really coordinate and kind of have a big picture. So, an example that has come to the audience, for example, was Dam Sally Davis. Somebody who has the ability to will the political power and the resources, and also can make the sectors speak to each other: human health, animal health, and veterinarian. And from there on, I think that the governance for the different needs will have very specific specificities. And in terms of the research and innovation ecosystem, that is a challenge of integrating, I would argue, the academic research, the industry, and then perhaps government-supported research. So the leadership and the governance is something that we need to think about broadly in terms of path forward.
Now, are you finding the same situation as Dr. Wright and the excellent work that you're doing, but you're losing talented researchers to foreign countries because of the better opportunities there, because of the investment opportunities in climate and investment climate in other countries?
Absolutely. I think that whether it is lost to other countries or lost to other fields, meaning that one may have a very talented young scientist working on antimicrobial resistance, and
sorry for interrupting. Time is up for Mr. Baldinelli. Maybe you will get an opportunity in the second round to answer that. We will now go to MP McKelvey for 6 minutes. Please go ahead.
Thank you, Madam Chair. My first question is, Dr. Rubin, you mentioned a term I hadn't heard before, harmonized susceptibility testing. So I was just hoping you could outline more, like what the recommendations would be around that, and also around surveillance in general and how we can do better.
Thank you for the question. So when bacteria are tested for antibiotic resistance, it's essential that this testing is done in a highly standardized way. And in veterinary medicine, there's quite a number of organisms where we don't have kind of internationally agreed upon testing guidelines. And this has left diagnostic labs in many cases to sort of work around these gaps, which has led to some sort of fragmented approaches across the country in terms of how some bacteria are tested and characterized. I think working together, we could come up with some more harmonized approaches of how this might be done, whether it's in terms of interpreting the test results or actually conducting the tests themselves. Veterinary medicine includes, or animals are infected with many bacteria that aren't widely encountered in human medicine as well. And so these are bacteria that are under research. There's less information known about them. And so we lack some of those standardized methods. With respect to surveillance, having standardized methods allows us to directly compare what's done in my lab, for instance, with a lab on the other side of the country. We know that both researchers or both diagnosticians would get the same result if working with the same organism when using standardized conditions. So it really facilitates the use of routinely generated diagnostic data, which is paid for by someone else. It's paid for by the end user, the client who's requested those tests, or the veterinarian who's requested those tests. And it gives us kind of a window into what's going on from a resistance perspective without having to put as much financial resources as is required for active surveillance.
And Dr. Rubin, who would be our best international partners on such approaches? Is it the WHO? Who do we need to be working with better?
From the perspective of surveillance, this is a little bit outside of my area of expertise. I mean, certainly within Canada, we actually have a lot of our own domestic knowledge and some very well-respected researchers and scientists within the Public Health Agency of Canada. As we heard from Dr. Wright, there's a lot of strength there on an agricultural animal and food within the agricultural animal and food sector. The CPARS program does fantastic work and is really an international model for how to do resistance surveillance. So I think a lot of that expertise is really homegrown and easily available to us here in Canada.
Thank you. And Dr. Nguyen, I was wondering if you could also share, you mentioned, the human, the animal, the veterinarian, in that sort of collaboration. So looking internationally, are there other countries that are really having those groups talk together in a good way that we could use as a model?
I can speak perhaps from the research standpoint. I think that Sweden is certainly an example. Denmark is certainly an example where they have done remarkable work in integrating research in the policy making and with the industry, as well as how to integrate human and animal and environmental health together.
Great. Dr. Skinner, you really eloquently laid out, it's easy to focus on, I guess, the low mortality, bulk organisms, things where you can mass produce, and maybe not as much investment into rarer or more deadly. And then you mentioned some international participation, maybe around pull incentives. So I was just wondering if you could kind of lay that out a little more, like how do we ensure that we're focusing on the most problematic microorganisms?
That's a great question. I think simply put, there are a number of organizations around the world that look to address this. The World Health Organization semi-annually produces a report that identifies the most dangerous drug-resistant organisms, and they survey around the world and do surveillance to understand those which are at greatest risk for humans. That's published semi-annually. That's prioritized into the highest concern, middle and lower concern, but still of great concern. The CDC does something similar. Other jurisdictions do likewise. And this surveillance in hospitals to understand the morbidity and mortality these organisms can cause, the lack of effective antibiotics is pretty clearly identified. So the pull incentives ought to be and have been designed to incentivize antibiotics that treat these most dangerous pathogens. And it's important to keep that in mind as Canada did that, and I believe the pilot would do exactly that.
How much time do I have? 7 seconds. I have 7 seconds. I get another round. I can ask more questions later.
Thank you. With that, we will now proceed to Mr. MP Blanchet-Jonca for 6 minutes. Please go ahead.
Merci. Première question pour...
Thank you. My first question for Dr. Nguyen. You called it a disastrous economic situation and a battle against these antimicrobial. Canada is the only country of the G7 that contributes so little. It's on the bottom of the scale. Do you think that we should be investing also in prevention, like One Health? Do you think that might be more effective in the long term? Well, I'm certainly not an economist, but I'm not really the best person to discuss economic costs in particular. Canada has a lot of unrealized potential, and we have a lot of work to do to channel the political will, first of all, in order to get a national, pan-Canadian plan and strategy, which we could begin there, and then take the necessary steps to realize that. Experts seem to say that climate change is also a factor in the growth or the spread of these resistant antibacterial. we're ready to spend billions on a pipeline, Trans Mountain. Now, how does that compare as a budget to the fight against antimicrobial resistance? Well, Canada has to take a step back and have a larger picture of its future. National security for the needs, economic security, of course, but given various epidemics and pandemics, we have to also act to secure our health. Canada can invest, can afford to invest. In the early 2000s, or rather 80s, when HIV began to spread, we found the money to fight it. Now, we're still spending $40 million a year for the fight against HIV. And now if we could see that ARM is just as critical to its future and the health of its population, thereby national health security, they'd be prepared to invest. You know, political will means political power. So for the last 20 years, we have had chronic underfunding for a lot of these. Other countries in the G7 and the OECD, what would be the role of these underfunded universities without necessarily obviously, you must feel that they are absolutely essential to a successful campaign, university research. We often forget in innovation, it often starts in a university. There's a lot of in innovation and research in a lot of fields, but particularly the life sciences and health areas. Also, the entire ecosystem of research. These researchers become experts, and they are there to train the next generation of researchers and experts. It needs a great spirit of collaboration and cooperation between and among universities, particularly in Quebec. But all academic institutions and establishments are make a contribution to the public good and society. The academic network will help to arrive at a solution to ARM. Well, in fact, you stole my thunder because we are trying to diversify our economy, industrially, for one thing, but at the basis of any diversification, you have to innovate. And to innovate, you need to research. Now, we will make great steps forward in technology, but we can't do it without research and innovation. What levers should we activate in order to optimize or promote the capacity that we do have in Quebec and Canada? Well, yes. Well, there are individual researchers with great experience and good reputation worldwide on ARM. There are teams at work also. And I'll go back to this concept of leadership, the issue of leadership. You have to transcend these jurisdictions and the obstacles that exist, administrative policy barriers, political barriers. Because there are excellent ideas out there, but we have to be able to have access. So the opportunities are there.
For 5 minutes, please go ahead.
Thank you, Madam Chair, and thank you to all the witnesses that have joined us tonight. Recent AMR stats in Canada that can be compared against the 2018 stats referenced by the Pan-Canadian Action Plan on AMR. Current stats referenced are very outdated. My question is to Dr. Skinner. Do you feel since 2018, with regards to Canada and AMR, is it getting worse? Is it stable? How bad is it in Canada?
I think that's a question that really demands data. And to your point, data from 2018 is very difficult to understand what that means today, some 7 years later. I can tell you around the rest of the world, based on reports that are recently out, one from the WHO this month, that AMR has gotten significantly worse over the past 7 years. We know during COVID that AMR got worse in the United States. It's hard to believe it didn't get worse every place else. It is a growing problem. A genie out of the bottle. It's very difficult to get control out of it, even with all the tools that we have. And we need to dedicate more work to that holistically, everything from infection prevention to proper diagnostics, antibiotic stewardship, and delivering the right antibiotic to the patient at the right time.
Just some follow-up questions, sir. Outside of the United States, what countries suffer the most from AMR? What countries suffer the least? What is the regional spread of AMR across Canada?
That also, to answer your last question first, that's also very challenging. That demands surveillance across the geographies, and surveillance is more easily done in urban centers and tertiary hospitals than it is in rural communities. That's true in Canada, that's true in the United States, that's true around the world. The global burden of AMR is highest in many of the low and middle income countries. India reports very high burden. Parts of Africa, Southeast Asia have extremely high burdens and growing. We know Eastern Europe has high burdens relative to Western Europe. We know the Nordic countries do extremely well as far as antimicrobial resistance due to a number of policies they have, including understanding who enters the hospital carrying a drug-resistant microbe and being very active in containment of those patients and the like. So it varies widely across the world. It varies substantially within jurisdictions between rural and urban settings and between cities.
As the leader of the AMR Action Fund, how do you feel about the state of AMR research, innovation, and commercialization in Canada?
There's first-class research in Canada. We've known that for a long time. I've worked in the biotech and pharmaceutical industry and investing for many decades. I've invested in Canada. I think the challenge in the AMR space specifically is that the market is broken, and so the investors are lacking. And trying to take innovation coming out of academia and advance that and translate that into drugs and bring those to patients is really the critical shortfall. Good ideas are just not financeable when investors won't invest, and that's the current state of affairs. That's why we need the pull incentives we've been talking about to make sure that there's a financial incentive in Canada and around the world to bring investors back into the field to make sure that the innovation can advance and that we can have the new drugs that patients need desperately.
Is Canada reliant on foreign countries to manufacture cures?
I think the short answer is yes, and I think that's true for the U.S. as well. The innovation has been moving to other jurisdictions where it exists at all. China's becoming ever more active in research and development in antimicrobials, as well as the manufacture of drugs. That is the challenge that we see in shortages around the world for antibiotics with some frequency, due to a number of factors. Could be a storm that damages a factory in the U.S. or in Europe or in Canada. And that may be one of two factories that produce this drug for the world. And if we damage one, the supply chain is fractured, and it can take months or years to rebuild that. And we've seen that with shortages, and I think we see that with branded pharmaceuticals as well, and particularly in the anti-infective space.
Do Canadians have access to enough cures and antibiotics? How does Canada's access compare to the AMR cures? And
time is up.
Okay.
Okay, well,
Thank you, Madam Chair.
Thank you. We will now proceed to MP Noor Mohammed. Please go ahead. You will have 5 minutes.
Thank you, Madam Chair, and thank you to the witnesses for being here. Let's start with Dr. Nguyen. If you could, you struck by what you said, and indeed, this is something that really, for all of you, but I'd like to lead off with you, Dr. Nguyen, in terms of the solutions that we need to be thinking about, the way in which we need to be thinking about this problem. If there are concrete, specific things that you think we should be doing differently or that Canada should be doing, what would those be? Maybe you can give us your top one or two so that we can take that back.
So in terms of the solutions, I think that first I would like to emphasize that it has to be a holistic and multi-pronged approach, whether it be stewardship, better access to antibiotics, diagnostics, and better surveillance. From what I wanted to highlight was throughout all of those major interventions, it needs to be innovation. Just using the tools that we have today better wouldn't be enough. And so from that point of view, to have better innovation so that the surveillance can be rapid and in real time, that diagnostics can be not take 3 to 5 days, that we have rapid diagnostics. It's the innovation that we need to invest in so that these multi-pronged interventions can work. I do not think that there is a single bullet, a silver bullet answer to that. So if one was to have one intervention, it would be to increase the resources so that we are able to implement these multi-pronged interventions.
And you had enumerated other countries and other regions where things are being done or where there's an opportunity to collaborate. Who would you say is our best comparator? Who is sort of and who is the gold standard? Which country would you say is the gold standard in how to address AMR? And I guess, are there lessons from that we should be taking away? Because through these conversations, and we're hearing a lot of interesting recommendations, we've heard that Canada is last in certain areas, we hear that Canada is leading in certain areas. But at its core, I think our objective is really to figure out how do we take what others are doing, take what we've learned, to figure out exactly how we end up leading on this. So if there are gold standard countries or best practices that you think we're missing in Canada, would love your thoughts on that. And then I'm also going to go to a couple of others with the same question.
So I think that an example that we could perhaps find inspiration in is probably Scandinavia. I think that there are many parallels between Canada and Scandinavia, both in terms of its universal health care, the relatively modest population to geography, and the ability that it has had to integrate different sectors, whether we view it from the One Health perspective, sectors of human, environmental, and animal, but also sectors where academic and public and private sectors have been able to work together. I perhaps not at the avant-garde, but certainly has been a strong proponent in terms of advocating for the role of its country in and the importance of AMR within its policy.
So I'm going to go to Dr. Skinner next with that question. But before I do you think that there is any issue, Dr. Nguyen, on not any issue, but do you think that the complexity that we see in Canada versus, say, Scandinavia in terms of some of this is because there are 13 different jurisdictions that are trying to also play their own individual roles in the management of AMR? And if so, how would you think about this in the context of the federated system that we have, such that we can kind of alleviate some of those issues and risks without, of course, the federal government saying we're taking over healthcare, which, of course, nobody wants us to do, but just thinking about how that would work?
Absolutely. I think that our federate structure, it is a core of the incredible complexity that we're dealing with. The separation of healthcare versus, animal health or drug approval, et cetera. And so if I do not know that I have a solution, but I think that food for thought is perhaps in 2021, there was a report actually chaired by Dr. Wright and Dr. Andrew Morris about the idea of what the AMR network might look like. And one of the proposal is to have this hub and spoke network structure where there's leadership both at the provincial level, but then across provinces. Each province with its own leadership would come together under a larger umbrella leadership. So this is a complex structure, but something I think that is really worth thinking about.
Time is up for Mr. Nur Mohammed, MP Nur Mohammed. We will now go to MP Blanchet Jonka. Please go ahead. You have 2.5 minutes.
Merci, Madame la Présidente. Je vais poser ma question pour Dr. Lagarde. Vous avez étudié...
My question is for Dr. Lagarde. You spoke of anti-ARM and the dairy herds in Quebec. Now, Quebec is a strong player on the dairy, and it's been trying to apply a real approach to animal health and human health and the environmental health. And in what measure will the importation of animals, whether they're for food or milk, will this contribute or slow down the research projects in Quebec? Well, that's a very good question. We don't import too much product currently. So you'd have to compare product to product. Different strain and different characteristics of resistance from product to product or from animal to animal, types of animals. We don't have enough data yet to be able to do that. Okay, you may have the answer if we defend a supply-based, supply-side system. Is that another way, perhaps, of protecting the public? Well, yes. If you ensure protection from antimicrobial resistant drugs in those species that are currently covered by the supply management chains, it's a small portion of the animal population, and there's very, very little transmission, perhaps, to husbands, to animals. Transferred from animals. The small proportion that may occur can be dealt with more easily. Thank you.
For Mr. Mahal and 2 minutes for MP McKelvey. So then we will end the panel. MP Mahal.
Thank you, Madam Chair. I would address my question to Dr. Nguyen. Dr. Nguyen, you just mentioned during your testimony that AMR is as critical as HIV and other life-threatening diseases. I think that also resonates with the concern that Dr. Bettina Hamlin raised the other day when she was saying that AMR is a present threat. It's not something that we can wait for future. So my question to you is that how satisfied are you with the current funding that are available for AMR research in Canada when it comes to the development of medicine and its availability and its marketability to Canada and for the Canadians?
I think it is grossly insufficient. I think just as a point of comparison, since we're talking about HIV, the currently 2025, where the HIV epidemic is, we are at 43 million per year for research in HIV and hepatitis, whereas for AMR, since 2021, there has been 28 million plus 6 over 5 years. So it is, almost multiple orders of magnitude, and so the resources are grossly insufficient.
My next question to you is, we understand that when we talk about drawing comparison with the single jurisdiction and multi-jurisdiction, do you, from your practical experience, do you see that it is actually a cause, or it is just a simple explanation of the situation or of the lack of will that, as you mentioned in your previous statement when you were given, that it's not about the research and talent that we have at the lab level, but it's lack of political will, it's lack of leadership. So which one is it?
Are you
Sorry
talking
for
about...
interrupting. Time is up, maybe. Okay, time is up for MP Mahal. So if you can respond to this in writing, that will be really great. It will be circulated to all the members. We will now end this panel with MP McKelvey for 2 minutes. Please go ahead.
Thank you, Madam Chair. My question is for Dr. Lagarde. I know that you study antimicrobial resistant E. coli in animals, and I was just wondering if you could speak to the interface with the environment, environmental reservoirs, wastewater, and our colleague mentioned, climate change and changing environments and how those might be an impact. And do we need to do more research in that regard? And I point that out because I realize that, we're these nice, warm, nutrient-rich bodies, and typically these organisms have not liked our Canadian environment. And just how does that also interface with international travel of other environments as well?
On a définitivement besoin plus de recherche sur le rôle.
We definitely need more research on the role of the environment with AMR. I'm interested in E. coli because it's available in many, many habitats and environments. And climate warming, of course, is playing a role. But we have to do some hard research to get the data to come to any real conclusions. We would have to add environmental elements or features in our surveillance programs. Currently, we don't really have sampling of the environment in these programs. Most surveillance programs don't study the microbes in the environment.
Want to thank the witnesses for appearing before the committee today. If there is anything you want to bring it to the committee's attention, you can always send us in writing, and we will always incorporate that. It will be distributed to the members. Thank you once again to the witnesses. If you want to leave, you can leave. I just have to make some announcement to the members for the upcoming meetings. So I will take like 2 minutes. So our next meetings will be on Monday, October 27th and Wednesday, October 29th. So we will commence and continue our study on how to best promote and grow private sector investment in research and development in Canada. I want to thank all those members who have submitted their partial list of witnesses. Just want to remind members that the committee adopted a motion to receive the full list of the witnesses by tomorrow, that is Thursday, October 23rd. And I just want to let everyone know that we are in touch with the Science Chief Advisor to schedule, but currently she is out of country. She is in Paris, and then she is going to Japan. So we will try. We are in communication, and we are trying to schedule as early as possible. I will update you once I have some more updates. And the last thing I wanted to bring to everyone's attention is that the documents received by the committee for the criteria study have been sent to the Translation Bureau. A very early assessment estimates that it could take them no less than 6 months. They will come back to the clerk with a more precise time frame as soon as they can. So these are the updates. I wanted to bring it to your attention. Do you want to say something? No, that's my question. Okay. So is it the will of the committee to adjourn the meeting? Yes. Okay, meeting is adjourned.